Assalamu alaikum. Hello, everybody. My name is Abdalrahman Tarawa, consultant of acute care medicine at Soba University Hospital. This session is an introductory session about medical professionalism and also introduction to medical ethics. The objective of this session to discuss principles of professionalism and to highlight physicians' commitment. We as physicians, we have certain commitment. We need to work on them so that we can fulfill our job. And also we'll introduce the concept of medical ethics and medical ethics. Professionalism is based upon ongoing use and display of appropriate attitude, core competency, and knowledge. Definitely, you need to have the technical skills. With the technical skills and competency, the attitude is the way you deliver your service to your customer, which is the patient. So it's about delivering values. You use our knowledge, our competency, and attitude. Professionalism, when you see it, you know it. Sometimes it is difficult to describe, but you can easily differentiate between someone who is professional and someone who is not. The most important document released in professionalism is the Physician Charter. It was released in 2002 by the American Association of Physicians, was published in Annals of Internal Medicine. If you put Physician Charter, you can access this document and it will be shared with you. There are 3 principles and 9 commitments. This principle, the principle of primacy of patient welfare, principle of patient autonomy, and principle of social justice. When we are the commitment, I divide them about those related to direct interaction with the patient and those which are important for our professional development and leadership. We need to be technically competent. We need to have the scientific foundation and knowledge, and we need to display honesty in every action. And confidentiality when we are dealing with patient information, and we have to have appropriate doctor-patient relationship. And at the same time, we need to manage conflict of interest. Whenever there is a conflict, we need to manage that. And personal and society leadership, this about we have to be accessible, we have to have competent to improve access to care, improve quality of care, and just distribution of finite resources. And we have also some professional responsibility. We'll go about them one by one. So the principle of patient welfare, this is the main job. We have a patient and we are the provider. So we would like to serve their interest. What is their main problem? What makes them come to your office? What makes them come to the hospital? So it is not about what you find, it is what is concerning them. And if what you find is more important than what concerns them, you need to explain that. And to serve patient interest, this requires altruism. This is the most important, and it contributes to relationship of doctor-patient relationship, and it creates trust. This service job should never be affected by any pressure from society, from government, from administrator, hospital administrator, because the main principle is the primacy of patient welfare. The second principle is, so in order to deliver the principle and to act on the principle of patient welfare, we need to be technically competent, we have the knowledge, we have the competency, and we need to focus on certain safety skills, general patient safety principles. We have to practice the medication safety, surgical safety. We need to observe infection prevention and control, and we need to communicate well, and we need to deliver our care based on the available resources. We have to be resource sensitive. The second principle is the principle of autonomy. For a long time, medicine was practiced through paternalism. The doctor sees what is right and he gives advice to his patient. But during 1960, 1970, with the advancement in technology, patients found that some intervention violates their values, some religious values, societal value. So we have to respect their self-determination, their choice. So physician must have respect for patient autonomy. We must be honest with our patient and we have to empower them to make informed decision about this treatment. We shouldn't manipulate our patient. This does not imply that the patient can choose inappropriate care. For example, if you have someone with acute myocardial infarction, the options are to get medical treatment. If it is ST elevation, the best is to go for a cath lab. If it's not available, they go for thrombolysis. Plus, they're getting medication. But if you want to put them in option, medical treatment, medical plus thrombolysis, or going for cath lab, the patient has to choose from these options. He cannot ask for colonoscopy, for example. He needs to choose from the available options. The third principle is the principle of social justice. Medical professional must promote justice in healthcare system, including fair distribution of healthcare resources. And this was so clear during the COVID epidemic. We have scarce and limited critical care bed or even hospital bed, and we need to prioritize who should stay home, who should come and get hospital, and even the criteria for oxygen therapy. In general practice, we used to give oxygen whenever saturation less than 94, but during COVID, if the patient is not distressed, you can give oxygen when saturation is less than 90. Physicians should work actively to eliminate discrimination in healthcare. We shouldn't differentiate between patients based on race, gender, socioeconomic status, ethnic group, religion, or any other social categories. So social justice imply no differentiation between patients, and at the same time, we need to distribute the healthcare resources in a reasonable manner. We have commitment. One of the most important commitment is to commitment to scientific knowledge. We should have, physicians have duty to uphold scientific standards, should be evidence-based. We should promote research so we can generate new evidence, and we need to create new knowledge, and we need to ensure its appropriate use. We need to use the knowledge based on the available context. The profession is responsible for the integrity of this knowledge, which is based on scientific evidence and physician experience. So we say that we apply the knowledge in the appropriate context. We have to be committed to maintain our competency. Commitment to lifelong learning. You know, some people, when they finish their degree, the medical school or postgraduate degree, this is the beginning of lifelong learning. You need to learn from literature, and you need to improve yourself, and you need to make sure this knowledge is appropriate to your patient and appropriate to the context of practice. In addition, we need to collaborate and develop team skills, which is necessary for provision of quality of care. Now, if you are working in ER, if you are doing endoscopy, doing surgery, doing angiogram, all these need teamwork. Even if you have a single patient in the floor, he needs a nurse, he needs a therapist, he needs a physiotherapist. Even your team is composed of junior doctor. So team skills is very crucial so that we can deliver successful service. We need to be honest. This is the most important moral value. We need all moral values, but honesty is the most important. Patients are completely and honestly informed before and after treatment. We need to explain why we are doing this to them, especially if you are doing a test, if you are doing procedure or surgery, or even if you are referring them to someone else or counseling, they need to know the basis, why you are doing this. And patient should be empowered to decide so that they can make informed consent in the course of therapy. And physicians should also acknowledge that in healthcare delivery is very complex and very complicated. And error can happen, adverse event can happen. And when these happen, we need to address them. We need to be honest. We need to tell what went wrong. We need to maintain patient safety during this process. Whenever errors occur, patient should be informed. Before informing him, if there is a life-threatening condition, we need to address that. We need to resuscitate, we need to treat, and we need to inform them. And also we need to analyze why this error happened, and then we can come out with a lesson learned so we can improve healthcare delivery system. Here, the commitment for confidentiality. Patient information is owned by the patient. He share it with you because he need help. He need explanation. He need treatment. He need cure. We need to protect this information. We cannot disclose without patient permission unless this is requested by law or in some situation for the benefit of the patient or when patient is endangering others. For example, someone with infectious disease which are, for example, the COVID, this need to be a notifiable disease. We have to maintain appropriate commitment to appropriate doctor-patient relationship. Patients are vulnerable, and vulnerability and dependency of patient. So certain relationship between physician and patient should be avoided. The relation that he come for service, he give you information, you need to assess, you need to do your workup, and then give him solution or explanation. We physicians should never exploit patient for any sexual advantage, personal or financial gain, or any other private purpose. This is very important because it's gonna destroy the doctor-patient relationship and it's gonna injure the profession as a whole. Commitment to improve quality of care. Physician must be dedicated to continuous improvement in the quality of care. This commitment entails not only maintaining clinical competence, but also working collaboratively with other professions to reduce medical error. So the quality is to give safe, patient-centered. You give the right care to the right person at the right time within the right context. So we need to reduce medical error. We need to increase patient safety. And we need to minimize overuse of healthcare resources and optimize the outcome of care. We need to creation and implementation of mechanism to encourage continuous improvement in the quality of care. And this come by discharge clinic, morbidity and mortality clinic, by incidence analysis. We also have commitment to improve access to care. Basic health care should be available and accessible. And this is a responsibility of the government that all population need access to primary care. But whenever you have clinic, you need to make yourself available. If you have certain refer clinic or emergency room time or hospital duty, you need to fulfill that job. You need to be there, you need to be available, you need to be accessible. We must individually and collectively strive to reduce barrier to quality of health care. And we have commitment to manage finite resources. We are required to provide healthcare that is based on wise and cost-effective management of limited clinical resources. The provision of unnecessary service not only expose one patient to avoidable harm and expense, but also diminish the resource available for others. For example, if you have a high dependency unit or coronary care unit bed, if you put someone who doesn't need it, then you prevent someone else who needs it, that bed. And also we have commitment to manage conflict of interest. Medical professionals and their organization have many opportunity to compromise their professional responsibility by pursuing private gain or personal advantage. Conflict of interest can come from medical equipment manufacturer, from pharmaceutical industry, insurance company, also from research, and also sometimes from relation. If you falsify a report, this is because of some relation with someone, this is also a conflict of interest. Physicians have an obligation to recognize, disclose to the general public, and deal with conflict of interest that arise in the course of their professional duty. Whenever there is a source for conflict, you need to disclose that to your institute, to the organizer, to the any governance body, so that it can be managed. As member of this professional, we are expected to work collaboratively to maximize patient care, be respectful of one another, and participate in the process of self-regulation. Self-regulation entitled satisfies the requirement of the regulatory body. If it is required for you to get certain process for license, or before you get to training, you need to do certain course, you need to comply with this regulation. You need to maintain the license if it need to be renewed at certain time. This is a professional responsibility, and we should know our scope of practice. If I am a physician, I'm not supposed to do surgery. If I am I get privilege to do certain surgery, I should know my limitation, and I need to know when I should call for help. And whenever there are errors, we need to find them, and we need to report them, and we need to learn from them so that we can improve system failure. The first part, which is about introduction to medical professionalism, we should remain committed to patient welfare and serve their interests. And we as physicians must reaffirm their active dedication to the principle of professionalism at personal and system level. So individually, when you are interact with the patient, but most important when you interact with the system, because usually system fail us. 90% of failure are due to system, but system is built by individual. Unless we recognize bad or incidents, we cannot improve the system. I will go directly to medical ethics, and we'll leave the discussion at the end of the talk. Ethics is part of life. When you are driving and you come through to stop light, if it is red, it is an ethical action, you stop. And it is ethical action, you respect the other people right when it is green so they can move. Ethics is dealing with the proper course of action. When you get something left, if there is a bag in your table, if you want to search for the owner, that's an ethical action. So ethics is part of life. We do it every day in our practice. It's the study of right and wrong. It answers the question, what do I do in this situation? What is the proper course of action? And medical ethics, it comes from this description with our medical knowledge and technical skills. It is just doing the right thing. But here, there are a lot of challenges. What is right at the beginning of life? Fertility ethics. End of life, when someone is dying. When we have limited resources, what is the ethical action? who should receive scarce medical resources, and when patients demand an acceptable measure. For example, if they request a test that is not indicated, shall you do it? And what is acceptable, how we define the acceptable intervention or measure. And when it is futile care, should we deliver that care? Essex is dealing with this question. This is an introductory session. Maybe in the future we can speak in more detail about futility of care and end of life ethics, because this needs special consideration. So when it is futility, how we define futility? Do we have a uniformly acceptable definition? Medical ethics refer to those guidelines and behavior we expect medical professional with moral integrity to exhibit. Again, guideline and behavior we expect medical professional. This means he has the technical knowledge. He has the know-how. With moral integrity, he has all moral values. And with the technical knowledge, with this moral value, then he should follow certain behavior. What are these behavior? It is summarizing these four principles: beneficence, do good; non-maleficence, do no harm; justice, and respect of autonomy. So we have four principles: do good, do no harm, respect of autonomy, and justice. Autonomy, it includes privacy, confidentiality, and self-determination. Usually people use self-determination instead of autonomy. So they are interchangeable words. When people say autonomy, most of the time they mean self-determination. But you have the technical knowledge, you have the competency, you have these skills. You need the all moral values, especially honesty and respect. Moral values are needed all the time. But respect and honesty, whenever you interact with your patient, you need to display honesty and respect. Sometimes you need courage, sometimes you need generosity. So it depends. But honesty and respect should always be there whenever you interact with a patient. And we need to be sensitive. And here we say this is situational. When dealing with sensitive issues, someone is dying, when it is futility, when it's organ donation, when it is about doctor-patient relationship, this is situational. So here in this situation, in sensitive situation, you need to observe this principle. You need a lot of empathy so you can display these principles. I tend to reflect on the driving power here. This is the moral value. The driving power is the moral value. And the compass, it's about those principles: do good versus do no harm. And autonomy, your personal right against justice, the society right. So do good versus do no harm, and your individual right against the society right. So you have the driving power, you have this, the compass give you the direction. And this is about situation. When you are driving in a difficult road, you need to slow down so that you don't injure yourself, and you don't injure someone else. And when you are dealing with futility, end of life care, you need to display a lot of empathy. You need to listen. You need to be actively listening. You need to understand these concerns. Where are they coming from? Then you can make sense and address their situation. The practice of medicine and ethics are inseparable. If one moves, the other will move, with it. Every medical decision involves an ethical decision. And I tell you an example. If you are in the outpatient clinic, you have someone with blood pressure of 200 multiple times. That patient is hypertensive. So the technical decision is to treat him. And the ethical decision is to give antihypertensive medication. Let's assume someone with systolic hypertension and you start to treat him. And with any single dose, he gets postural hypotension. He tell you, doctor, I cannot live. I feel threatened. I am afraid that I get injury. I'm afraid to get a fall and intracranial bleed or a hip fracture. You know, all these medication are giving me bad side effect. I don't want them. Though the technical decision is to treat hypertension, but when it comes to do good and do no harm, this patient might be in danger with medication. So here, the ethical decision is do no harm, and at the same time, we need to respect his autonomy. The beneficence versus non-maleficence, do good versus do no harm. Beneficence, action done for the benefit of other. We are here and we are there to help our patient by giving explanation, by counseling them, by giving treatment that can aim for cure or controlling their disease. And sometimes we need to go through difficult, complex procedure. Do no harm, non-maleficence, we should refrain from providing ineffective treatment, acting with malice towards our patient. We should avoid any kind of harm. Someone with common cold, why are you giving an antibiotic? Someone who's healthy, why do you give him multivitamin for life? Always we need to weigh and balance beneficence versus non-maleficence. The harm when it is carelessness, when it is malaise, vinegar, dislike, these can injure and endanger and harm our patient. There are certain conditions that increase our tendency of doing harm. We call them the capital A, when we are impaired with alcohol or drug, when someone wants to commit adultery, which is illegal sex, and someone wants to commit illegal abortion. Association, if we are linked to certain industry, or if we own a lab or pharmacy, we should avoid ordering unnecessary tests. And when you advertise for yourself, you need to give sound, sensible information. You don't describe yourself with something that you don't have. There are certain challenges when we try to balance do good versus do no harm. So beneficial action, it's about resuscitation, someone who's arrested or someone who's severely hypertensive or hypoxic, provide vaccination to the general population, that is doing good. Encourage someone to quit smoking, start exercise program. All these are beneficial, treating certain conditions like diabetes, hypertension, chronic kidney disease, and so on. Non-maleficence is stop ineffective medication or harmful. If the patient get allergy from the medication, you stop it. If he gets severe side effect, you need to manipulate or reduce the dose or stop that or change that medication. Refuse to provide ineffective treatment. And here I see many of us are treating a lot of viral illnesses with antibiotic. We are contributing to the antimicrobial resistance. We are endangering the patient and we are endangering the profession and the society. Many beneficial therapy have serious risk. The pertinent ethical issue if the benefit outweigh the burden. For example, if you are giving insulin to treat hyperglycemia and diabetes, we know that insulin can lead to hypoglycemia. Sometimes it could be severe and fatal. So we need to balance the dose. We need to educate the patient how he can recognize the hypoglycemia, and when it happens, how he can manage that. If I get someone with advanced cancer stage 4 who has been diabetic for a long time, and now he gets hypoglycemia with a tiny dose of insulin, and he's going for palliative care, maybe it is time to stop insulin. Balancing beneficence and non-maleficence display role in every medical decision, whether you are ordering a particular test, giving medication, doing procedure or operation, or any kind of treatment like counseling and so. So beneficence and non-maleficence are there all the time. Whenever we do any interaction with a patient, we need to balance doing good versus do no harm. The risk that can happen to our patient could be physical, someone you chop his leg, or a lady if you remove her uterus. It could be a financial harm if you expose them to a financial burden if they can be treated at home and you admit them to hospital. If they can be admitted to a room and you admit them to high dependency or critical care area. It could be social. If you label someone with HIV, hepatitis B or C, COVID at one time was a social stigma. It could be moral or religious. And you know, the Jehovah Witness, they don't want to get blood transfusion. So uh, they think it is a sin. I had a patient who's Jehovah Witness, has a ruptured diverticulitis, and he needed surgery. And he said, hey, doc, I prefer to die with my disease than to receive this blood. We need to, so the risk, the moral and religious risk is weighed by the patient. We need to understand uh, this situation. And I tell you, whenever there is something coming from religious belief or social belief, you cannot change it. You need to explain, you need to address, and you need to respect their choice. This gentleman, he's 72 with diabetes for 30 years, hypertension, and stage 4 kidney disease. His creatinine is 4.6. And he has amputated leg because of diabetes. And he has retinopathy. And at the same time, you see him eating baklava. And it doesn't go with all the illnesses he has. So even the patient make a bad choice, the only thing you can do is to educate, explain to him. And this is, let us dive in autonomy. Autonomy is patient's independence. He has the right to make decision and to make choice. Competent adult has the right to make decision, and patient must be capable of rational thought. He should be competent and should have the capacity to make a decision, shouldn't be manipulated. So, and he can refuse the intervention. And as I mentioned about the Jehovah Witness. So the guy on the previous scenario, he knows the problem with the diabetes, but he's still eating sugar and kunafa, which is a baklava. In most clinical setting, different goals and approaches are possible, outcomes are uncertain, and intervention can cause both benefit and harm. And I give you an example. Someone with acute myocardial infarction, ST elevation. The best choice is to give him medication and to take him to the cath lab. Or the complication rate is less than thrombolysis. But also, the second choice is to get thrombolysis with TPA or with streptokinase. And the third choice is just to get the medical management if you are in somewhere where you don't have thrombolytics and cath lab. And the fourth choice, not if he refuses to take anything. So in most clinical settings, different goals and approaches are possible. Outcome are uncertain. Intervention can cause both benefit. Sometimes you subject the patient to the best treatment, but he can get a devastating and serious complication. You take him to cath lab and he can get a serious intracerebral bleed or retroperitoneal bleed. Outcome are uncertain. Intervention can cause both benefit and harm. This scenario was a real story. It happened in 2006. Dr. Bansal, orthopedic surgeon who practiced near New Delhi, he performed beggar on amputation on beggar. Some people, they want to be professional beggar and they want their leg to be amputated. So he chops their leg. So patient come to the office autonomously and competent and demanding amputation. Definitely, we are not supposed to give, it's not part of the medical practice. I remember a story that in UK, one of the schizophrenic guys came to the office and he asked the doctor to chop his leg. The doctor said, no way. So the guy went home and he put them in ice bag. The second day, it was gangrenous and they have to chop it. Maybe the first day, the doctor can recognize this patient serious, this patient need a social worker or a family member or need to be admitted in certain context. Anyhow, at the first visit, amputation was not indicated because it is not acceptable. If patient asks an acceptable measure, we don't comply with that. But the second day, when he injured himself, then it become must. So we respect patient choice, we respect their autonomy, uh, but limitation on autonomy. If the patient has limited capacity, and here I would like to differentiate between capacity and competency. Competency is a legal term. It is declared by a judge. The judge say this guy is not competent to make decision. It is all or none. He cannot make any decision. If the judge says this guy is not competent, he cannot make any decision, medical or financial or anything. Capacity is a medical term. Some patients have limited capacity and some patients, they don't have it. When they don't have the capacity, they become incompetent. But sometimes you can discuss simple issue. If your patient have pneumonia, you can tell him you have infection and this can be treated with IV antibiotic. But they cannot participate in complex. If you tell them you want to open their tummy, and then if it is you're going to take a frozen section, and then you go to this complicated description, some people in moderate Alzheimer's disease, they cannot understand and comprehend. So they have limited capacity. In emergency situation, if we don't have stated choice, we will assume most of the patient accept what is acceptable by most of the population. If you get someone with shock, most people when come to the emergency room, they take blood. So here, even if he's shocked and confused, it is okay. You take administrative decision to physician, they can decide to give him blood. This is an emergency care. Fetal care should not be delivered. If the intervention are not going to benefit the patient, we are not supposed to deliver that care. If it is a futile surgery, advanced tumor, you don't do it. Futility sometimes depend on the context. When I was practicing, I had a guy with massive bowel infarction. This is in Sudan, is a futile disease. In some, where else this gentleman can receive bowel transplantation. Liver transplant, now it is done in many parts of the world. But if it is not accessible in your city and the patient cannot be transferred somewhere else, then it is a futile disease. When patients ask an acceptable measure, we don't respect their autonomy. The guy who said, chop my leg, we don't respect that autonomy. And when there is a public hazard, if someone with HIV, one day I had a patient, diagnosed him with HIV, and he told the registrar, don't tell his brother. The guy was encephalopathic. His brother asked the registrar not to tell his wife. No way, we should tell her because she's at risk. We go to the third component. Here we discussed, initially we discussed beneficence, non-maleficence, and autonomy. Now we go to justice. And if you see the picture, justice is different from equality. Equality, you give them the same, but justice, it is try to meet the objective. They want to see the match, then this guy doesn't need stool, this need one, and this need two. Justice is a concept of moral rightness based on ethics, rationality, law, religion, and equity. Me giving the other what is due to them, it's a fair distribution of benefit, risk, and cost. Early 2000 years ago, physician initially applies the term patient to their paying client in the upper class, distinguishing them from non-paying, اللي هم sick poor. This is injustice in labeling. Those who pay, you label them as patient, and those who doesn't pay, they label them as sick poor. When we would like to distribute resources, there are many ways, but I elected here just two commonly used: egalitarianism and utilitarianism. In medical setting, justice involves the allocation of healthcare resources in a fair way. Egalitarianism, for example, we say we give CT scan to Khartoum, one in Madani, one in Al-Fashir, one in Kasala, one in Adbara. You put the same equipment anywhere. But utilitarianism, you maximize the total or the average welfare across the whole society. For example, Madani, it's a city where you have a lot of road traffic accident. You can give a lot of trauma resources there. If you have certain area with non-communicable disease, then you give them resources for non-communicable. If tuberculosis or malignancy are common in certain area, you give them resources to meet their needs. Individuals should be treated the same unless they differ in a way that is relevant to the situation in which they are involved. Uh, Justifying differential treatment that can be done based on the need, desire, contribution, and effort. This patient, she's a 38-year-old housekeeper. She's married. She has 3 kids. And she got pregnant now with the 4th baby. Unfortunately, her husband had stroke. She need to work to support the family. And she had labor pain. And she took a taxi to the hospital, and she called her family, but by the time she reached the hospital, there was no family member. And the staff profiled her as illegal pregnancy. She was not accompanied by family. There is no grooming for a lady who's coming for labor, and they profile her as illegal pregnancy. Unfortunately, they did episiotomy without anesthesia to punish her. So punishment is not our job. If you want to punish society, you need to go to be a judge, to go to the justice department. As medical professional, if you get someone getting trouble because of alcoholism, getting trouble because of drug, your role is to help him with the acute problem. Your role is to counsel him, to refer him to appropriate psychiatric management. But you cannot decide this guy is not appropriate to society and you cannot punish him. So justice, fairness with respect to the distribution of medical resources, who should receive scarce medical resource, how should we distribute them, and what is the best outcome. And the last component is confidentiality, natural human desire for privacy, fear of social embarrassment, disapproval, fear of discrimination, stigmatization, fear of information misuse against the patient. It's important. It's a natural human desire for privacy, fear of social embarrassment or disapproval, fear of discrimination, stigmatization, information misuse against patients. So confidentiality is very important. It builds confidence and open communication. It respects patient privacy, dignity, individuality. It encourages free exchange of information, which is crucial for effective medical intervention, public health effort, and preventing harm to the other. The 2 words, privacy and confidentiality, like interchangeable words. We use the one meaning the other. Privacy is the right of individuals to keep information about themselves from being disclosed. Patients decide who, when, where to share their health information. On the other hand, confidentiality. How we as healthcare workers treat private information once it has been disclosed to us. The patient has the information and he decides when to give you and how much. If you are my registrar, you need to go into detail. If I ask you for consultation, I give you the information that help you to make a decision. But this information should be protected by the institute. It is not right for everybody to come and look at the record. We can disclose information if it is required by law for the benefit of the patient and to prevent harm to the other. So when the patient endanger others, we can inform them. I remember one time I had a guy who was homeless and he was encephalopathic, and I had to put an ad on the newspaper. So unluckily, we were able to find his family, and they came and they helped him in the process of medical care. Always observe confidentiality. If the patient asks you not to share the information, this is his right. Confidentiality dies with the patient. If he tell you not to tell someone and he die, You are not supposed to tell anyone unless required by the law or if there is danger to someone else. We should observe more when it is related to sexually transmitted disease, when it is related to drug and alcohol dependence, and when it is psychiatric illness. People, they want to keep them more than other diseases like diabetes and hypertension. But for whatever medical condition, if the patient asks not to share information, then it is his choice. So take home, moral values are crucial for ethical practice. We need to weigh and balance beneficence versus non-maleficence, good versus bad. Well-informed patient has the right to decide for himself and herself. Information is owned by the patient and he decides when to disclose them. After we receive this information, we have to protect the concept of confidentiality, but we can disclose information in certain situations. And at the same time, judgment is important tool and it can be learned gradually. It's important for ethical practice and it's important for professional practice. And thank you very much.